And good evening, everyone. Here we are again, and we are looking forward to another presentation by Dr. Mendel, a spinal neurosurgeon from Miami, and we're very much looking forward to our presentation tonight on cancer immunotherapy. I'd like to start with an introduction of the panel. So let's start with, I see Dr. Bennett there.
Yeah.
Greetings, everybody.
Exciting.
It's good to be starting again. I'm glad Richard got it together with the internet, and I'm looking forward to hearing it once again.
Thank you very much.
Nice
Hi,
haircut, Dr. Bennett.
Hi, Ben. How are you?
Good. How are you guys?
Great. Nice to see you.
Nice to see you too.
And Slavin, nice to see you.
Hello. Nice to see you too.
Introduction.
Introduction. Should I say something about introduction?
Where are you, Slavin?
I'm in Slav now in Croatia. That is a city near Zagreb, the capital of Croatia. It is 8 p.m. here, and I'm honored to be here with you tonight. Should I say something about myself?
Yes, please.
Yes, I'm a third-year medical student at the University of Zagreb Medical School and director of the Rod and Cranial Anatomy and Surgical Approaches course, which I designed with my colleagues at the University of Zagreb Medical School, which teaches students and interested public in neurosurgical procedures and approaches.
Thank you very much, and we're looking forward to presentations from you perhaps in the future. Thank you.
Of course.
Okay, thank you very much. And Dr. Mendel, would you like to start? Thank you.
Oh, sure. Yeah, Slavin, you know that there's a beautiful anatomy course on the Congress of Neurosurgery website that shows all the petrosectomies and all the beautiful videos of anatomy for the surgical approaches. Have you seen that?
Can you tell me the name of these videos?
Well, if you go to the Congress of Neurosurgery, it's cns.org, and Aaron Cohen Goodall is the editor.
I've seen that. Yes.
Yeah.
I have even contacted Dr. Goodall because I was amazed by the videos. I wanted to say my respect. So I think that these videos are impressive and a great resource. Thank you.
Yeah, because he's very interested in disseminating that stuff.
Yes.
All right, so we'll talk about cancer immunotherapy, and the best kind of summation I saw of this was in the April 3rd issue of Science, and that issue of Science also had David Baltimore and a big group of consensus people talking about the ethical limits and scientific limits now on CRISPR, which we talked about before. And I don't know if you guys saw this, but CRISPR did get the Innovation of the Year award by the triple AAAS and Science. So we had talked about that a few months ago. CRISPR-Cas9 technology. So cancer immunotherapy is really a something that's been going on kind of behind the scenes forever, but cancer immunotherapy is really now the fourth pillar of oncology, with surgery, radiation, chemotherapy, and now cancer immunotherapy. And I think that it's going to get so important that in 50 years from now, we may have people not understanding where cancer immunotherapy stops and chemotherapy begins. So it's been about 15 years. I think it was 1996 is the first. 96. No, now it's about in 2000 the journal Science first published the positive results of some cancer immunotherapy, which was modifying T cells' behavior towards cancers, but that was a mice model. Now, here in 2015, we're really starting to see big advances in immunotherapy, enough that it's become, the fourth pillar of treatment. This is a book by Sue Armstrong, and it's published by Bloomsbury, the Signet Press. P53, and it's called the gene that cracked the cancer code. P53 was one of the early genes. It was probably the first gene early on that gave a lot of insight into the potential of immunotherapy. But it was quite a while until, in the 60s and 70s, we had ideas about what T cells might be able to do if you could harness the strength of them. So now T cells can really be modified, and the techniques that you have to be familiar with are the following. One is that T cells aren't attacking cancer cells. What we're doing is using antibodies to target what are the inhibitory proteins on the surface of the T cells, so that we can actually magnify them and magnify their response to cancer. So in people that are immunosuppressed, what we do is, manipulate their inhibitory mechanisms to get a T cell to really respond and magnify its potential to lyse or kill cancer cells. There's another technique now called adoptive T cells therapy, and this is a far cry from what 20 and 30 years ago we used, which is leucovorin rescue, which was terrible. But when you talk to people that have had stem cell transplants in the last decade or so, they didn't enjoy the experience, but it was nowhere near the nightmare that it used to be. And then we're also seeing advances in the tumor vaccines. I'm sure right now you've probably seen a lot about vaccines, the potential for vaccines in the Ebola virus, and also for some forms of meningitis now. So this is the important idea. What you're seeing here is tumor epithelial cells, and you're seeing that you get an antigen and a major histocompatibility complex, an MHC, and what you're seeing is the antigen attaching to the major histocompatibility complex on top of one of the T cell receptors, and you're seeing no T cell proliferation. But here now we're able to manipulate the T cell response by what are being called positive co-stimulation, and finding factors that will turn off the inhibitory mechanisms on the surface of the T cell, so that the T cell responds by releasing cytokines and killing cancer cells. So one of the really big theories with cancer immunotherapy now is how to find the checkpoints, where to find all these inhibitory functions, and so that's what's being called like cancer checkpoint or immunotherapy checkpoint analysis, and that's the that's the topic of the webinar on January 19th that the double AAAS, triple AS is sponsoring. So what you see here are these checkpoints. So by manipulating different checkpoints, and a lot of this isn't going to be done. This isn't going to be done by a scientist one at a time. This is going to be like combinatorial chemistry or combinatorial mathematics to figure out, where these checkpoints may be, so that things are going to accelerate really quickly now that we have an idea of what it is that needs to be manipulated. Before we really just didn't know what was going on. We were trying to have T cells kill cancer cells, but instead you could just take a T cell, manipulate the proteins on the surface of the cell, and have tremendously magnified, an exponential increase in their ability to kill cancer cells. So and this is going to be obvious to you now, but this is going to be much more complicated in a very short time than probably people realized decades ago. Because now the things like tumor microenvironments are going to become very important. When I was taking immunology in the 80s, it was kind of a theoretical thing where you'd see nice colored diagrams of triangles and squares and boxes and ideas about one thing killing another. But, it really wasn't well. It was like that cartoon where it says, and here a miracle happens, and then you have the result. We didn't know what was going on. So we're going to talk about the understanding of tumor microenvironments now. So, on the left, example A is just an example of a lot of...
What is the noise?
All right, so on the left is just an example of a microenvironment that expresses a lot of things in the environment that can be manipulated. But here, a immunogenic tumor you see is dark, and so you may get some kind of positive response, but it may not be, a durable response that lasts a long time, and it may not lead to cures unless we figure out what else needs to be manipulated in the environment. So it's just like when we talk about, how bacteria and the microbiota of the intestines is so important. That's probably going to be important in tumor microenvironments too. So this diagram here is an example of adoptive cell transfer and how cells can be treated and evaluated for specific tumors to recognize things in them, and then you have a better chance of controlling the cancer. And there could be preconditioning as well, and this is kind of an example of the preconditioning. These, every one of these diagrams comes out of the Science April 3rd, 2015 issue. Now, what's going to happen, I think, in the near future, and this is what I was talking about, chemotherapy and immunotherapy are a lot different to you and I because we saw the development of both of them, not both, but immunotherapy. But I think in the future, immunotherapy is going to become such an important part of oncology that it's going to be very confusing where chemotherapy stops and immunotherapy begins. So I think these are going to kind of merge together as we kind of learn more. Now, to go back here, these are the things you really want to familiarize yourself with: the antibody targeting inhibitory proteins on T cells, and most importantly, though, adoptive T cell therapy, tumor vaccines. These are all things that are happening now, but the thing that's driving all that at the moment is this: the blockade of different checkpoints. So figuring out where the inhibitory functions are that control the T cells and releasing them so that there could be a lot magnified response. That's going to be, I think, the main focus in immunotherapy for the time being. And I think if you're kind of familiar with these four ideas, and the idea that remembering that we're killing cancer cells as a result of targeting T cell inhibitory pathways. We're not killing, we're not aiming at the cancer, we're aiming at the inhibitory pathways, and the T cells are taking care of things by their magnified response, which is kind of interesting. But that's really all I have to say about the immunology. This was kind of interesting because immunology in the 80s wasn't all that complex, and a lot of it was magic box type of things. But all these advances, I think, are really well covered in that book by Sue Armstrong, P53. That's really about it for now. I'd like to talk about neuroimmunology next time.
Yes.
But I think you have to have a good feel for where things are right now.
Boy, when you were talking about how when you were in medical school in the 80s that we didn't know as much as you do now, and I got to tell you, I struggled through the immunology section of my medical school, and it came up again in the systems even in more detail. But looking at your slides again, I realized that how much I've already forgotten and how I need to get back into it. And it's just so important, but it's so exciting. I wonder where we're going in the next step. If from the 80s to 2015 we've come this far, I wonder if we're going to learn so much more in the next 10 years. It's really exciting.
I think a lot of it for me was the rise of AIDS too, because I can tell you that I don't remember anything about CD4, CD8 cells in the immunology course.
Really?
And when I was an intern by 1989 or 90, I mean, there were so many HIV patients. We were checking CD4, CD8 counts all the time. I kind of had to figure out where all that stuff came from. I did not remember it I don't remember it in medical school.
I suppose for Slaven also in Croatia, we're all studying the same things.
Yes.
So deeply you were involved in immunology, and
Yes.
now you're in the final part of your course. Are you forgetting some of it?
Well, of course, we never went into too much detail about it, but I can see that immunology is the most basic and advanced thing in medicine today, because most of the therapies that were not very developed are now based on immunotherapy, and I think this is a great lecture about that. This is one of the most fascinating parts of the battle against cancer, and I've been thinking of whatever I think it is. So thank you very much.
So in the next section, I'm talking about neuroimmunology. What would we be covering? What would be some topics that maybe we could prepare and be ready for? What should we?
Let me look at it some more and figure out what a good way to introduce it is. I mean, I'll try to start with the basics, and it'll probably take two talks, at least, just to get you comfortable with the ideas. You know, there's been immunotherapy in neuro-oncology for a long time, but it was not at all very successful. I think if you remember months ago, there was a urologist who was on and was asking something about herpes vectors that were being introduced to Duke. Goes back to the 70s and 80s. Herpes vectors. And, you know, people have tried a lot of things, and I'll try to go over some of the history, but we'll talk about where the real science is right now, not just by trying to talk about what the vectors are. That's more, you know, like virology and all that. So, you know, you can start looking at it. I'll try to put something together. I'm going to be pretty busy this first week because, you know, the new year, and probably I won't be able to do it until the week after, the Saturday after this, because I've just got a lot going on in the practice right now. But why don't we plan on that? What's today, the 2nd? So would it be the 16th or the 15th? I think the 15th, right? Saturday. What day is?
Yeah, that's right. Today is well, for me it's
2nd.
16th. Huh? 16th is a Saturday.
All right, so let's do that Saturday, and we'll start on neuroimmunology.
Wonderful, thank you.
Yeah, I think that would be a good. I mean, I think this will be enough to get started on the neuroimmunology. You know, there's lots of buzzwords and abbreviations in here in the immunology section, but I think if you just understand these ideas, that gets you where you need to be to begin on the neuroimmunology.
Thank you. So Slevin or Ven, do you have anything to say? Any questions?
Well, questions are many, but I would very much like to hear the section on neuroimmunology, because just to get the whole picture, I'm kind of impressed that these topics that we can discuss and learn more about them. I'm not so brave to speak about this because I find it very complex and a field of never-ending studying. So
Yes.
I would be glad if I could hear. So if any questions arise, I will be glad to ask them. Thank you.
Thank you.
John.
Oh.
Yeah, thank you, Dr. Mendel. Thank you for bringing, you know, more information into light, especially about these checkpoint system. I mean, I'm not aware of this before.
Yeah,
so,
and that's why that webinar on January 19th, it's probably going to be free to register for. So just go to, you know, www.aaas.org, and that's the you know, those are the publishers of Science, and that's where the webinar will be.
Okay.
I was thinking about, hey, John, if you were an ER doc at the time, when was the first time you ever heard of CD4 and CD8 cells? It had to be with HIV, right?
Yep.
Oh, you're muted. We can't hear you.
Oh, that's okay. I understand.
Dr. Bennett, we cannot hear you. You seem to be muted.
Where is he? I mean, he's like floating in the air.
Yeah, I think he's having connection problems like I had.
Muting. Yeah.
Well, look, if you guys have any questions, just you let me know or email
I'm sorry,
me.
we can't see you at the moment, Dr. Mendel.
Oh, okay, hold on. Let me turn this off. We turn off the screen share, right?
Yes, please.
I maybe have one question, but it's not a long or complex question. Can you just tell me what are the vectors that you are now making that you are now watching for now that assist you in these methods of therapy? I have heard that there have been some rather unsuccessful tryings in the 90s. So I'm interested. What are the vectors of the present? You were talking about viruses.
Yeah, there was a lot of talk about herpes vectors in the 80s and 90s, and I know that at the University of Oregon, Ed Newalt and did a lot with blood-brain barrier disruptions and things that would expose, would hopefully deliver more of an active agent to the tumors. But I will look at what the current vectors are now. This is not my specialty. I'm just reading about it now. But the herpes vectors and the use of things to contain tumor cells in neurosurgery has a long history. There was even a discussion over the last year or two. There came to light some ethical concerns about someone who had employed the use of, I think it was E. coli, to contain the growth of a cancer, a neuro-oncologic cancer, and that's come up before in an anecdotal fashion. But I'll try to include that in the talk on neuroimmunology.
Thank you.
But there have been people that have contaminated tumors with things like E. coli, and I want to double check on this before presenting the data. But I think this really goes back a long way. I think this has been tried for decades.
Yes, thank you very much. This is a very complex topic. That is why I asked you this question.
No, it's a good question. It's just I don't want to give you false information. But I think when you look back on what has been tried long before the days of the FDA and things like that, I think there have been a lot of things that have been tried to control the growth of brain tumors.
Alert from System UI server. Low battery.
I do. I also.
Alert from
I'm sorry.
Low battery.
Okay.
Also, you'll hear also too when people talk about, and the science behind this is not good, but it's quoted all the time. If you look at glioblastomas, in the 70s, there was a lot of suggestion that cannabis, or tetrahydrocannabis, which is the active ingredient in marijuana, did in fact have some effect on the control of glioblastomas. Honestly, I don't think it was much control, but you don't need much if it hits the lay press. It becomes an argument for legalizing everything. But I think that so many things have been tried to control, malignant brain tumors. I'm pretty sure feces is on that list, E. coli. But I will look that. I'll check into that.
Thank you.
Thank you very much. Dr. Bennett, can you talk now? he's a stationary figure.
Where is he now?
I think he went to the fridge to grab a beer.
He's having some internet problems.
Yeah, I think he had some infrastructure problems like I had.
It happens to all of us.
So let me try to get some stuff together for the neuroimmunology portion, and we'll talk about that and kind of go from there. All right.
Okay. Thank you.
Great. Thank you very much.
All right. I'll speak to you later.
Okay, I'll go off of this broadcast. Thank you so much, Dr. Mendel.
All right.
Thank you
Bye.
Very much.
Bye-bye. Thank you.
Bye.